Hello, everyone. Thank you for joining us for the first webinar of the series, So Now What? Helping Parents and Caregivers Navigate a School Year Like No Other. My name is Yu Ling Chang, and I'm the co-producer of Remake Learning Days across America, as well as the ambassador for kidsburg.org. When we put the series together, we realized that parents everywhere are going through the same thing. We're navigating something we've never had to navigate before. And at the heart of it, we worry about our children and what to do to make this a good year for them. So tonight we begin with COVID-19 and kids' health. More on that in one moment. Next week, we will host a double header. The first session at 7 p.m. is about supporting young children's social and emotional wellness. And the series features WQED, PBS Kids, Fred Rogers Productions, and Fred Rogers Center. And then at 8 p.m., we will do a session on tweens, teens, and mental health with Common Sense Media. Coming up on future Wednesdays, we'll also cover how do you communicate with your parent or teachers? How can you be an effective partner with your teachers so that your child has a successful school year? And this will be with Learning Heroes. And then we'll do one on tech safety and balance with Common Sense Media, and we'll end with learning resources. So tonight, we began with COVID-19 and kids' health, an evidence-based practical guide and FAQ. Our speaker tonight is Dr. Megan Freeman. She is the Senior Pediatric Infectious Diseases Fellow at UPMC Children's Hospital of Pittsburgh. She attended University of Kentucky and Vanderbilt University, where she studied coronaviruses. She's authored multiple publications in this field and also wrote the book chapter in the most recent edition of Nelson Pediatrics focused on coronavirus. In a moment, we will dive into Dr. Freeman's presentation that we recorded earlier this evening. We missed just the beginning of it, so we apologize for that, but the majority of the information is still in this video. So she begins with what is COVID-19, and we'll dive right in there. Thank you.
When I'm talking about the virus and also COVID-19 throughout the talk. So human coronaviruses cause two different types of diseases. There are actually 7 different types of coronaviruses that infect humans, and many of you have probably had 1 or 2 of them throughout the course of your life. So 4 of the coronaviruses cause the common cold. They circulate every winter and can cause just the run-of-the-mill common cold. And then 3 of them have been these emerging infections that can really cause much more serious disease and have had different degrees of spread throughout the world. So this first happened in 2002 with SARS coronavirus 1, and SARS stands for severe acute respiratory syndrome because that's what we were seeing with that virus. About 10 years later, in 2012, another coronavirus called MERS, or Middle East Respiratory Syndrome, came to be, and that one's actually still circulating in the Middle East, but it hasn't caused nearly as much trouble as SARS coronavirus 2, the cause of COVID-19. And these viruses can look very differently from one another. So with the common cold, while you might have symptoms of headache, maybe a fever, sore throat, cough, runny nose, maybe you'll be home for a day or 2, but you might not even have to miss work. These emerging infections can cause much more severe disease, including some of those same symptoms, but also some more serious symptoms, including serious pneumonia, respiratory failure that can cause someone to need support at a hospital or an ICU with a ventilator, as well as multi-system organ failure and death. So these are much more extreme. And one of the interesting things that has come to be with SARS coronavirus 2 is while it does cause severe disease in some people, other people have very mild disease and might not be showing any symptoms at all, despite the fact that they're infected. So this has made this virus very difficult to identify who is infected and to keep them separate from others with contact tracing and quarantine. So how is SARS coronavirus 2 transmitted? This has gotten a lot of media attention with somewhat different results. So there is a difference between what we call droplet transmission and also airborne transmission. So droplet transmission is when a respiratory virus, like SARS coronavirus 2, hitches a ride on a droplet that comes out of a person's mouth when they are talking or speaking or breathing in a space. And you can imagine a person might make more respiratory droplets if they're shouting or singing or working hard and exercising than they would if they're sitting quietly. And these droplets will travel about 6 feet from a person's mouth before they start to fall to the ground. And they can land on things or people that are in their path. So this is really why masks help. So if you're wearing a mask, then the amount of respiratory droplets that you are able to release from your mouth that can travel a distance is greatly decreased. The idea of airborne transmission is really a lot more like if someone was in a room and they were infected and then they left the room, the next person that walks through the room, much like walking through a cloud of perfume, would be able to come into contact with the pathogen. As a scientist, I will never say never. It probably is possible that this is a minority transmission route, but far and away, the most common way that this virus is transmitted is through the respiratory droplet. We also hear a bit about contact transmission, and that's the idea that if an infected person went somewhere like the grocery store and they weren't wearing a mask and they sneezed on a tub of yogurt, and then the next person comes along and touches that plastic tub, then they would get virus on their hands that they would then transfer to their own eyes, nose, or mouth when they touch their face. So this is why we are encouraging frequent hand hygiene so that no one infects themselves from this manner. This virus cannot infect you through your skin. It can only infect you through the mucous membranes of your eyes, your nose, and your mouth. So that's why hand washing is a really good intervention to prevent those contacts from occurring. So what are the symptoms in children? The tough thing about this virus in children is that it looks a little bit different than it does in adults. So while most adults have fever, 88%, something less than 40% of children will have fever. Cough is common in adults at 68% of patients, but only 50% in children. Children are less likely to have fatigue. They're less likely to make phlegm or sputum. They're less likely to have shortness of breath. And interestingly, they're more likely to have a sore throat than an adult or a headache than an adult. So those might be some things that you could look out for when you're going into the school year as well. And children are more likely than adults then to fall into this asymptomatic category. This gets a little bit confusing as well. So if a person is infected, they can really experience the disease in 3 different ways. The first way is asymptomatic. That means the person is infected, they can spread the virus to others, but they do not experience any symptoms. The second category is what we call pre-symptomatic, which means that while the person is infected, doesn't experience any symptoms and can spread the virus to others, they might find that in a day or 2, they start to develop the symptoms. So that's pre-symptomatic. And then the third category is a symptomatic person. So that's a person who starts to feel crummy and then knows that they are infected with SARS coronavirus 2. You've also probably heard a bit about this inflammatory syndrome of children. It's been compared a lot to a syndrome called Kawasaki disease that we've known about for decades, which is thought to be triggered by an infection. This syndrome is called MISC-C or MISC, depending on what part of the country you live in, and it stands for Multisystem Inflammatory Syndrome in Children. It's comparatively rare. It's a very small number of children develop this syndrome after they have been exposed to SARS coronavirus 2. And this is thought to be more of an inflammatory driven process in someone that is genetically predisposed to having that cascade and less of a virally driven process. These patients can be quite ill. They can require hospitalization. They can need ICU level care and support of different medicines in the ICU. But because we've treated Kawasaki disease for so many years, we actually have a really good treatment strategy for patients that come to the hospital with MIS-C. So as long as we're able to identify them rapidly and give them the support and the anti-inflammatories that they need, many of them are able to recover quite well. How long are infected people contagious? So the timelines of COVID get a little bit confusing as well. So if someone is exposed to the virus, then they have an incubation period, which is the period of time between exposure and the development of symptoms. While on average, people will develop symptoms around 5 days, it can be as long as 14 days before we will see symptoms. And that is why the recommendation is to stay at home and quarantine for 2 weeks if it is known that you've come into contact with a person that has COVID-19. The infectious period is thought to be around 8 to 10 days after a person develops symptoms. A lot of viruses, and this one is not an exception, tend to be more transmissible or easier to spread to others at the beginning of the infection. And that's because the levels of virus or the numbers of virus that are available in a sick person's nose to be able to be spread are much higher at the beginning of the virus before your immune system has started to do its work to decrease those numbers. The illness on average lasts for 10 days, but some people do report symptoms for longer periods of time. And you are released from isolation at around the 14-day point after exposure, or at least 10 days after the development of symptoms. Can children spread COVID-19 to others? This was a super hot question for really the entirety of the beginning of the outbreak, and one that we didn't have a lot of data to go on until a little later on in the summer. I think the best case study that really tells us that children are capable of spreading this virus to one another and to adults comes from a summer camp in Georgia. So this summer camp had mask requirement for the staff, but not for the campers. And the campers were doing all sorts of normal camp things, interacting with one another, sleeping in tents together, and really coming into close contact throughout the course of the day. One of the requirements to enter the camp was to have a negative COVID test within 12 days of camp starting, but then that still allows for 12 days for that person to go out and acquire COVID. And that must be what has happened, because with only 3 days or so of this camp being operational, 44% of the nearly 600 campers had been infected with coronavirus. And this includes 51% of kids that were in the school age, so less than 12, and 44% of teenagers. So this really illustrates quite nicely that children are able to transmit this disease to others. How long does virus last on surfaces? So this data comes from some laboratory-based experiments where they specifically squirted a certain amount of virus onto a surface and then measured it to see how long it would last. And what they found is that if they aerosolized the virus, they were able to detect it for about 3 hours. That, just as a caveat, is a specific process that they used a machine to aerosolize the virus. It is not what is often happening when someone is speaking. It lasts on copper only for 4 hours. Copper is kind of an interesting metal. It has some antimicrobial properties at baseline. And then really applicable to the school situation, things like cardboard and paper, virus was able to be found 24 hours later. But on harder surfaces like stainless steel or plastic, thinking about doorknobs and toys and desks, these lasts for up to 3 days. So this is why it's really important to disinfect any type of surface that is in a high touch environment, or to try to avoid shared surfaces or high touch surfaces when possible. What about recommendations for disinfecting surfaces? So the EPA actually has a great list and really even an interactive tool that if you have a cleaner that you're curious about, you can look it up on their website and see what their recommendation is for if it is effective against coronavirus or not. In general, products that contain bleach, ethanol, or hydrogen peroxide are going to be effective. And one of the things that's important to remember about cleaning products, and is also, I think, pretty easy to forget, is that all of them are studied based on a certain amount of contact time, which means that they need to be sprayed on a surface, allowed to sit for a certain period of time before being wiped off. So I would make sure that you're familiar with kind of the rules of using those cleaners before they're really employed. And of course, whenever I'm giving a talk that involves kids and I'm talking about cleaners, I always have to remind everyone to keep them safely locked up away from especially the really young ones. So what about masks? How helpful are they really? Masks are one of the best things that we can do to prevent the spread of this virus from person to person. And that is because they trap respiratory droplets. Not only do they trap the droplets produced by the person wearing the mask, which protects the others around them, they also provide protection from others to the wearer. And that's because droplets of other people tend to get trapped in the outside of the mask. Because both the inside and the outside of the mask are considered to be contaminated, you should only put the mask on and off by the ear loops or the ties, and you should not touch the cloth part of the mask that covers the mouth. And you should always perform hand hygiene of either soap and water, 20 seconds, or alcohol-based hand sanitizer before and after manipulating a mask. I have heard it said that masks, much like underwear, need to be washed with frequency, and you should not share masks one to another within the family without washing them first. There was a paper that came out recently that did an experiment that looked at different types of masks. And the endpoint for their experiment was how many droplets were able to be measured coming out of a person's mouth. So they had one individual wear each mask and say the sentence, "Stay healthy, people," 5 times in a row. And they measured how many droplets came out of this person's mouth. The graph that I'm showing you, the green dot, is the number of droplets that occurs if you are not wearing a mask at all. That was actually 960 droplets over the course of those 5 sentences. And then they've normalized all of the other masks to that dot. So if the dot is below the green dot, it does a better job of preventing those droplets from extruding from the mouth. The main takeaway I see from this figure is that a variety of cotton masks are quite effective at reducing the number of droplets that are able to be released. The thing that is a little bit less clear as a result of this study is that the bandana and the fleece gaiter do not seem to perform as well as the fitted cloth masks. And I actually think that this might be a lot due to fit and not as much due to the material itself, because the cloth masks tend to be closer fitting to the face. I do get the question a lot about the use of face shields instead of a mask. And unfortunately, the evidence for the face shields is not as good. So while if you are talking directly in front of a person with a face shield, that person will be protected from the droplets, it does not protect as well as a mask from the sides or the bottom or the top. And the best anecdote that has come out of this outbreak specifically related to face shields was an infection outbreak in Sweden. So there was a restaurant in Sweden where some of the waiters were wearing face shields without masks, and some of the waiters were wearing masks. And all of the wearers of the face shield got infected and none of the wearers of the masks did, which is really kind of some evidence to support this idea. So face shields certainly can be used for eye protection, but they do not protect as well as the mask. Who should be masking at school? Kids, staff? So masking is more effective the more people do it. Children under 2 years old cannot wear a mask because it is both a choking and a suffocation hazard, so we can't recommend that. Otherwise, there are very few medical conditions that will not allow for the wearing of masks. And many medical conditions, I would actually encourage my patients to wear masks because it's even more important that they be protected from this infection. And then the graphic that I've got on the left there just really goes through the different levels of risk. So the lowest risk situation is when everyone is wearing a mask. It's a medium risk situation if one person is wearing a mask. It's a highest risk situation if no one is wearing a mask. And it's considered even a non-exposure if both people are wearing masks and they're 6 feet apart. So this comes into play when we think about contact tracing, people in the classroom, and really how to keep everyone as safe as possible as we go into this school year. I have gotten some questions about what if it is physically impossible to stay 6 feet apart from one another in a classroom, which certainly it often is. There are a couple of other things that we can do to decrease the risk. So one is to go outside whenever possible. So if you're able to take part of the class outside, then absolutely do that. If the second best thing is opening some windows to increase the airflow, that's also useful. Some schools are doing things like putting plastic barriers between rows of desks so that they could be kind of front to back farther apart, but side to side closer together. Some schools are using cohorting strategies so that the same 30 kids are together all day and are not mixing with hundreds of kids throughout the day, which would make the number of exposures less if one of those kids happened to get sick. And you can also do things like facing the desks in the same direction, facing the front of the room, as opposed to sitting in kind of groups that face one another. So how do masks and distancing really help? So this is why social distancing works. So let's look at the orange bar first. This is under a normal scenario. So if you have one person who is infected with SARS coronavirus 2, then in 5 days, they are likely to infect between 2 and 3 people. So that's depicted in this graphic as 2.5 people, which is, it's just numerical, half people. And then after 30 days, because each of those 2.5 people are going to go on to infect 2 to 3 other people, we'll end up with 406 infected people. And whenever there are more infected people in a community, we start to have a couple of different issues. One issue is it gets a lot harder to contact trace all of those people. So it's a lot harder to have the personnel at the health department call every one of those 406 people and then call all of their contacts in order to get everyone to stay home. The other thing that starts to get challenging is the testing scenario. So because a lot of the testing in this country is centralized through a certain company, the more cases there are, the more those tests kind of stack up on their bench, and the longer it takes for us to get those test results back. And social distancing and contact isolation is so much more effective when we find out that someone who was tested yesterday has this infection, as opposed to when we find out a week from now that someone has this infection. So those are some of the challenges that we start to have. If we do social distancing and masking, it decreases the number of infections that occur in the chain. So one infected person will infect half as many people, only 1.25 people. And then all of those 1.25 people will go on only to infect 1.25 more people, which means that in 30 days, we'll only have 15 infected people, which makes the strains on the system of contact tracing, isolation, and testing much easier for us to handle. What kind of hand hygiene can be used? So really the 2 recommended ways of cleaning hands are to wash hands with soap and water for 20 seconds, which is 2 happy birthdays or 2 ABCs, or to use 60% alcohol-based hand gel. I do sometimes get questions from schools about other chemical formulations of hand sanitizer, and these are actually not recommended by the FDA for the elimination of coronavirus. So the alcohol-based is the way to go. Who is at greatest risk of infection? We've all heard a lot about this at this point in the pandemic, but this virus tends to be worse for people that are older and people that have underlying health conditions. And the risk really goes up by decade. So we start to see an increase in the number of people who die with this infection in the 60s, and then that increases again in the 70s and also in the 80s. People who have underlying conditions like cardiovascular conditions, which could be heart disease or stroke, diabetes, respiratory diseases like COPD or hypertension, do also tend to have a harder time with this infection. Interestingly, we don't necessarily see the same thing with kids, especially thinking about kids with asthma. We haven't seen that they have much of a worse course than kids who do not have asthma. And then I often get the question about if kids with underlying medical conditions return to school. And a sort of related question is, what about kids with a high-risk adult at home? So if grandpa lives with you, or if mom has chemotherapy for cancer treatment or an organ transplant and is immunosuppressed, how do we think about sending those kids back to school? So this is one of those things that's going to have to be carefully weighed for every family. So we all take risks every day. Riding in a car, driving in a car is a risk. Back when I used to ride on planes before COVID started, that was certainly a risk. There are a lot of things that happen that are outside of our control, and we have to measure kind of the risk benefit of those sorts of situations. And this is not different than that, in that it's another risk that we're going to have to weigh. So each family has different risks and different benefits from sending their child to school. And this is going to be different from family to family based on kind of individual factors. One thing that I can tell you that is somewhat reassuring is that most kids handle COVID very well. And that even includes some kids that have medical complexity. So if you are worried about whatever condition it is that your child has, I would encourage you to call your pediatrician and have a discussion about it. Or if you have a specialist that you see, call them and have a discussion about what their opinion is of sending your kid back to school and what you might do to kind of help decrease the risks of infection. And then I do like to remind everyone that kids can transmit COVID to high-risk family members at home. So that is a risk to that family member if the kid is going out and potentially being exposed to this infection. Who should be staying home from school or be sent home from school? So I think this is going to be something that's going to be really tough this year. And that's because the symptoms, especially in kids, of this coronavirus infection look indistinguishable from a lot of other common colds and even influenza that will be circulating this winter. I am hopeful that because we are wearing masks and doing lots of hand washing and social distancing, that we will see a decrease in all respiratory viruses, but that is kind of yet to be determined. It's just a hypothesis and a little bit of a hopeful hypothesis. So anyone with a fever should not be at school. Anyone with respiratory symptoms, including cough, congestion, and shortness of breath, should not be at school. And everyone should be referred to their physician to help decide if they need to be tested for COVID or have an additional evaluation. And I will tell you that I'm not only talking to groups of parents, I also talk to groups of community pediatricians, and we are trying to come up with kind of the best and most painless plan for how to implement this going forward so that we can be ready to help everyone with these decisions. I often get questions about other than kind of book learning, other associated events that come with school. So things like PE or choir, band or orchestra. And some of these special scenarios do present some special problems in COVID times. Unfortunately, we had an example early on in the outbreak where there was a choir practice where one person was symptomatic with COVID-19. And they infected 87% of their choir during the course of the hour rehearsal. There are a lot of kind of high-risk behaviors that are associated with a choir practicing. So singing produces more respiratory droplets that go farther than just speaking. And often choirs stand very close together on bleachers. So this is going to be one of those scenarios that might take a little bit of creativity, whether we're able to do rehearsals outside for a period of time, smaller groups, standing farther apart. These are going to be some strategies that we're going to need to do in order to try to make this as low risk as possible. And we're going to have to apply some of those sorts of ideas to things like wind instruments, when selecting what sorts of exercises might be appropriate or not appropriate for PE this year. And then I often get the question about kids' sports as well. And this is another situation that it's not one size fits all. So different sports are going to have different risks. Anything where you are in close contact with another human or a group of humans that are not wearing masks is a risk. So things like swimming and diving in a not very crowded pool are less risky than a huddle of any kind that is unmasked, whether it's in the gym or it's outside. I had found this survey of parents in May that basically just said that a lot of sports parents are having some hesitancy about sending their kids back to sports. And I'm sure a lot of you have talked about this with your peers as well. And a lot of the calculus is going to depend, again, on assessing the risk of having your child involved in these sorts of things. So if I were a parent of a sports playing child, there's a couple things that I would want to know, and that includes how is my team going to handle if there's a COVID exposure, what kinds of practices are being put into place, when are masks encouraged or not encouraged, what are the rules, and how are we going to adapt to evolving data as the season goes on. So there's some resources that I just wanted to share with you before we move into the question answer section of this talk. The one on the top is called explaincovid.com, and it has a lot of evidence-based facts about what COVID is, how it spread from person to person, and it also kind of does a good job of presenting all of this literature in easily understandable pages. I've also put websites for the Allegheny County Department of Health as well as the Health Department for the state of Pennsylvania. These are really important. So one of the things that is the most important about all of these decisions is understanding how much spread is happening in your community. So in Allegheny County, we've actually been on the downtrend for the last week or two, which I find really encouraging, but that's something that I check every day to see kind of how things are changing in the community. You can follow the health department on Twitter, and they release the information around 11 or 12 every day. Because the more cases there are, the higher the risk. The fewer cases there are, the lower the risk. So this is really important to know in your area. And then I've also included the Johns Hopkins tracker, has a lot of information about kind of the cases across the world and across the country, and also some information from the Children's Hospital there at the bottom. So with that, I'm going to close out, and I think that Yu Ling is going to moderate some questions for me.
Thank you, Dr. Freeman. That was amazing and excellent and well explained. In particular, all the images that you've shown us. We do have some questions, so I'm actually going to start with a question that just came in, which is, does all the information that you just shared equally apply for infants and toddlers? So really, really young children.
So I can tell you a little bit about infants and toddlers based on some of my own data that I've been gathering about infections in our region. So infants and toddlers are more likely to have fever, cough with this infection than older kids. And it looks like, I will tell you that a minority of children have been hospitalized with this infection at all, but the younger guys do tend to land in the hospital with a little bit more frequency than the older ones. And sometimes that tends to be because of a feeding refusal more than because their respiratory symptoms are bad. I think that's probably the best that I can tell you. The other thing that we do know is, you know, they can get infected, and they often get infected because of someone that is caring for them, usually someone that lives in the home, but we have had some infections that have been associated with other caretakers as well.
Great, thank you. I know this is a question that my husband and I spoke a lot about, which is school buses. You shared a little bit of information about how sports and things like that work, but what about school buses as you're going to school?
Oh man, I had a slide about school buses and I took it out because of time. So school bus is a tough scenario, and I'm sure every district is going to handle it a little bit differently. I would say the optimal way to decrease risk on the school bus would be to have kind of some alcohol-based hand sanitizer on the way in. Masks would be required. You would be able to distance every other seat or so, often with like a taped area that says, you know, don't sit here to help guide people. And the windows being open as long as weather is permitting would also be useful, as well as cleaning the school bus, wiping it down after groups of kids have been on the school bus. I realize that a lot of these things are probably impractical because it's expensive to run school buses, and depending on how the district is doing, either, I know some places are doing like half volume, so then that would probably be a half volume school bus, but if everyone's going to school, then probably the bus is not going to be able to be half full.
Thank you. You spoke earlier about the transmission, and that's primarily droplet or contact, and it goes through the eyes, nose, or mouth. But there was a couple questions about what it can increase somebody's risk. And so one question is related to diabetes. Another has to do with BMI. If you're overweight, can that contribute to a higher risk? And then there's also a question about the bathroom and flushing and how do bathroom breaks work? I mean, it's, you know, it's something people don't want to talk about, but it is a question that we all wonder.
I am happy to talk about it, no problem. So I'll talk the first question about kind of pre-existing medical conditions first. So there has been some data in adults that does suggest that conditions like diabetes or obesity could lead to a worse outcome. However, the silver lining is that doesn't seem to be true for kids. So I have looked at kind of the courses of thousands of kids at this point, and even kids with cancer handle this quite well. there are some kids that do get severe infection. I don't want you to have the takeaway that none do, but most, even some kids with pretty severe conditions, handle this quite well. Now the question about the bathrooms. So this, I feel like, was high drama maybe in about May or so. There was some information that virus was able to be detected in feces, and that this is a really disturbing term called the fecal plume that occurs when one flushes a toilet, might be able to spray virus kind of throughout the bathroom, which certainly is concerning. A couple of things that I want to tell you to be reassuring. So there are a couple of different ways that we detect virus. The most common ones, the kind of Q-tip that goes up one's nose, is a type of test that looks for virus genetic material. It does not tell me this virus is alive and can replicate in someone else, or this virus has died. The same test was applied to the stool. The way that we can tell if a virus is able to replicate is to culture it. It's tough to do for this virus because it's so contagious. There are a lot of biosafety constraints upon who can work with this virus. But in studies where they have tried to culture virus, it is very readily cultured from one's nose. It is almost never cultured from stool. I don't think I've seen a single report where a particle from stool was able to go on and infect some cells. So I think that's really reassuring against these ideas of kind of fecal transmission from the toilet. So when schools have asked me kind of about cleaning and disinfecting bathrooms, it's not practical to disinfect the bathroom after every single person that uses it, but I would recommend that they increase their frequency of cleaning just to make sure that all those high touch surfaces are really disinfected.
That's good to know. So a few more questions. These are all great questions. Thank you everyone for submitting them. So you shared some of these resources, and I think these next set of questions relate to resources. So if you wanted to track the rate of death in children, is one of these resources one that you would recommend? Or would you recommend they go to another site?
You know, the CDC has a pretty good website that does separate out some of the data by age. The Allegheny County Health Department does separate out data by age, as does the Pennsylvania Department of Health. It's going to be a little bit tough to find case fatality rate in children just because luckily very few children have died of this infection. So it's not a metric that's super easy to find.
Great. And then similarly, chemical-free cleaning agents. I think you referenced a site earlier in your presentation. So even for cleaners like that, could they input that information in and find out how effective it is?
I have not tested that website with a lot of kind of alternative cleaning supplies. So you're just going to have to Google EPA and COVID and try it out.
Great. And are any of these materials available in Spanish or Chinese or other languages?
I have not done an exhaustive search. I'm sure that some of them probably are, but I can't point you specifically in those directions.
Okay, great, thanks. Last question. So this is a follow-up question about younger children and how symptoms may be different. A follow-up question to that is, are they any more or less likely to transmit the virus than older children?
I wish we knew more about this. We're learning more all the time, specifically in the 0 to 2 age group. I think it's a little bit harder to know. There has been some reasonable studies kind of looking at the transmission dynamics between like school age and teenagers. Teenagers behave more like adults, which I think is not surprising. Their biology is a lot more similar to adults. One of the things that we have going for us in the younger children kind of age cohort is that in order for this virus to get into a cell and to replicate, the cell has to express the receptor, and the receptor, it's kind of like a lock and key situation. So if the right lock isn't on the cell, then the key of the virus is not able to open it to replicate. This receptor is called ACE2. And we've learned that children don't have as much ACE2 in their airways as adults. And that's, new data during the course of this pandemic because no one had needed to look at that before. But that might be one of the reasons why children tend to have a milder infection. I will tell you though that children can have just as much virus in their nose when we count the number of genomes as adults. And children often forget their manners maybe a little bit more than adults do when it comes to putting things in their mouth or sneezing or coughing on one another. So those are some things that are working against us a little bit. We definitely know that transmission is possible in all of those age groups. I don't have great data on children under 2.
Thank you. I think even for adults, I mean, I didn't realize how much I touched my face when I first started wearing a
Yeah.
mask.
They've done studies of college students who are being videotaped, and they know that they're counting how many times they touch their face. And it's something like 20 to 100 times per hour that someone touches their face without paying attention.
Wow. I'm not surprised by that. I am going to ask 2 more questions and then we will wrap this up. So another follow-up question to discussion about feces. Is there anything about urine that we should know about?
I've never seen a study that has detected viral material in urine. I've looked for studies about vomit. I haven't seen that people have examined that. It's very rarely found in the blood. That's usually in someone that is ICU level sick. They're able to find it in blood. The far and away kind of worst secretion to deal with is the respiratory secretion.
Great. And then the last question, this is one that I get a lot from my friends, and this is mask breaks. So maybe you're on a play date, you're visiting your relatives, you're 6 feet apart, you're wearing masks. Is it okay to take a little mask break?
Especially if it is, this is another thing that has levels of risk, right? So if it's maybe the one other family that you ever see, maybe you can be a little bit more relaxed with them. This has actually also brought up a whole other cadre of interesting interpersonal dynamics, like who can be my pod friend? Do they have the same rules that I have as far as safety? Who is that family then allowed to see? I would just encourage you that if you're forming one of these relationships with some people that you're already friends with, just make sure you have a good discussion about kind of expectations and communication going in. I think that's going to make it a lot easier. And if you're 6 feet away and having a little break from your mask, that is totally fine. All the better if it's also outside.
Great. Well, thank you so much, Dr. Freeman. This was incredible. To all the attendees, thank you for joining us. We will be putting these resources in a resource folder, which you will have access to. We will send you the bit.ly link. It's also on the next slide, I believe. And so you'll be able to find this presentation there shortly, along with some other things. We also hope that you'll continue to join us for the following Wednesdays. Please share this information with your friends. Thank you so much. Thank you, Dr. Freeman.
You're very welcome. Thanks so much for having me. Stay safe out there, everybody.